Hello, and welcome to this presentation on measurement-based care best practices as part of the virtual forum on collaborative care. My name is Rajeev Krishna. I am a child psychiatrist and chief of medical staff for child and adolescent psychiatry at Shepherd Pratt Health System in Baltimore. I'd like to also introduce my co-presenter and let her introduce herself, Dr. Jeffries.
Thank you, Dr. Krishna. My name is Jessica Jeffrey. So wonderful to be here today. I am an associate professor of child, adolescent, and adult psychiatry at the University of California, Los Angeles. My roles at UCLA include acting as our associate vice chair of clinical affairs, as well as the co-director of our division of population behavioral health for the Department of Psychiatry and Biobehavioral Sciences. And intimately related to the topic we're going to discuss today around measurement-based care best practices, I am our lead psychiatrist overseeing our pediatric integrated care program for UCLA Health called Behavioral Health Associates. So again, such a pleasure to be here today, and I look forward to spending this time with you as we delve into this really important topic.
So I'm going to begin the first part of this presentation, and we'll then be handing it over to Dr. Jeffries for the next section. Again, this is part of the virtual forum on collaborative care in child mental health. Specifically, this is forum number 4 on measurement-based care best practices in this space. Our agenda, our learning objectives for today, what we want everyone to get out of this is to just have an understanding of what are the benefits of using measurement-based care in clinical practice, how it can be used to facilitate management in collaborative care, where you're in situations where you're not necessarily engaging directly with the patient. It's certainly a different form of practice than what we're often trained on or used to, and then recognize some of the common measures that could be useful in this setting. So to get to that material, we're going to start out by just covering what is measurement-based care and also how are we talking about collaborative care? What is that interaction pattern that we are specifying? The term is used in a lot of different areas, and how can measurement-based care apply to these collaborative care settings? And then we'll be talking about those implementation strategies with a really extensive case example to kind of walk through how could this work in those settings. So to get us started, what is measurement-based care? Hopefully, some of this is a repeat in that there has been a lot of material out there on measurement-based care already, but we want to make sure that we're also kind of starting from the same framework. And this is really the underlying reason why it is worth doing this. So measurement-based care, as we are talking about it, is the practice of systematically administering consistent assessments to patients as part of their care process. Those assessments assess whatever we're trying to treat at that point in time and can be used to then directly feed back into how we approach treatment for those conditions. In psychiatry, that really translates to administering generally rating scales, generally patient-reported rating scales are often the most practical way to do this. And then using the results of those rating scales to collaborate with our patients, both on how they are progressing in their treatment and what changes may need to be done in their treatment progression. Important features of this, these are not a substitute for the clinical judgment and decision-making around the treatment itself. They're an augmentative value. And what we know is that they need to be clinically actionable to actually have the benefits that they're able to have. They need to be current. They need to be interpretable within the context of the encounter that you're having with the patient. And then you really need to inform the treatment plan. They can't be just a side event that is happening but isn't driving the treatment process. We use measurement-based care at a basic level because it works, and it actually works better than not using it. And really, the ship has sailed on this one. That is a known thing that has been demonstrated in multiple disciplines, including in psychiatry, in adult and child, like kind of across the board. It is recognized that done properly, this can improve the quality of our clinical outcomes. So can lead to greater and faster reduction in symptoms, detecting symptoms that we often can miss as clinicians because we are having different types of interactions with patients, and this very systematically asks the same assessments consistently every time. It helps to bridge the gap in understanding between patients and clinicians and improve that therapeutic relationship by bringing some alignment around what are the elements of care that we're talking about and looking at. In that, it also improves the patient care experience, and there's data for all of these things. It facilitates the patient's own recognition of their symptoms and their ability to report those symptoms. It helps their understanding of what those symptoms mean, which can help with translating across stigma, getting increased buy-in to treatment, a whole host of other things. And it gives them a sense of agency in the process. It's not just that my provider is doing something, it is that I really have a stake in the game as well. And the other big deal about this is that it is really effective. One of the kind of obvious go-tos to point to this is that clinical protocols in randomized controlled trials often have better results than routine care. And it's not because the velocity is different in the controlled trial that is leading to the better outcome. It is that as part of the structure of a controlled trial, you are effectively doing measurement-based care. You are tracking the outcome, and you are often adjusting treatment amongst the study parameters, but also amongst what is the response that you're getting based on the data of those outcomes. So there's ample evidence even outside of the specific literature on measurement-based care that this works, and it comes simply from that disconnect that occurs between what we see in randomized controlled trials and what we see in routine care for the same types of treatments. But again, there are also multiple articles clearly demonstrating the effectiveness of measurement-based care, sometimes pretty substantial and significant benefits between actually administering and consistently using measurement-based care versus the sort of control arm that was more based on clinical judgment. And there's also data, and I know we often, as professionals, tend to resist this, but there is data that clinical judgment often misses symptoms, and it is very easy in the course of a treatment program to miss things that are otherwise caught if you're being very systematic about how you're asking those questions, and to utilize that data then to improve clinical practice. So that's the broad strokes on measurement-based care. The next thing we want to be very clear about is, what do we mean by collaborative care? The term collaborative care is often used to describe a lot of different care models that can range from sort of co-located care to this type of collaborative working with the PCP care to just pure consultation to everything in between. And so we want to be clear on what we are talking about in this context, because it matters in terms of what the benefits are that measurement-based care brings to this equation. So when we're talking about collaborative care in this presentation, we're talking about the idea of the primary care physician doing the primary interaction with the patient, providing the primary mental health care to the patient, with the psychiatrist, the mental health team really providing largely ongoing consultation and support to the primary care provider, with the ability to do some direct visits with the patient if necessary. But the real goal is to force multiply that mental health team by working with the primary care provider to improve the quality of what they are able to deliver for their whole host of patients in a really effective way. Now, as part of the generally well-recognized models for delivering this type of collaborative care, you also want to have some interface layers in between. The mental health team is not taking on every single patient in the PCP's office. There's a specific subset, and we generally track that by means of a registry, which is essentially this data layer that sits between the PCP and the I shouldn't say between, but that is worked with by both the PCP team and the mental health team to agree upon who are the patients that we are tracking in this model, and how are we tracking them, and what are the discussions that we need to have about them to assess how they're doing and how to help those patients keep making progress without needing to fall into more explicit separate mental health care resources. Measurement-based care and the data coming from measurement-based care is driven by the PCP in terms of the implementation of collecting the data, but fits into the relationship and into collaborative care as part of this registry. This really highlights some of the key advantages of utilizing measurement-based care in this space, because one of the things that it does, sitting in that registry, in that interface layer, is it provides a common framework for the mental health team and the primary care providers in their discussions as well. It helps to normalize those conversations and to be clear about what are the aspects of the mental health challenges the patient's having that are being treated, and how and why, in the same way that it might help a psychiatrist in their independent practice speaking directly with the patient. And in this setting, it can then help the PCP to also be able to communicate consistently with the patient. So it serves as a foundational layer in some ways that can help keep the entire treatment team operating towards the same goals and on the same page, which is particularly important when you have this type of setting where there are lots of cooks in the kitchen. So with that overview, I'm going to turn it over to Dr. Jeffries to walk through a case example and a evaluation of a number of the measures that are available to utilize in this space that can help with quality of care.
All right. Thank you for that really excellent overview. So what we're going to do now is we're going to really focus on a case study. And what we would like to do with this case study, again, and with that really excellent and thorough outline of collaborative care, really talk about the role of measurement-based care within a collaborative care practice. We will touch a little bit on these measures that can be used as part of a registry, but also really want to make sure to go through this case and focus on best practices in terms also of how do we use measurement-based care in evaluation of our patients to guide the treatment plan, and also to enhance patient experience to help them, the patients themselves, both children and their families, increase their sense of agency in the care provided. So all of these are really important principles of measurement-based care itself as a practice, as part of a collaborative care model. So let's go into this case example. This case is Lily, a 17-year-old female who presents her primary care provider's office, and she's feeling down after performing poorly on her midterm exams. Lily's PCP is concerned that she's exhibiting symptoms of depression, and she's asked to complete rating scales while in the clinic. So Lily is talking again in this collaborative care model with her primary care provider, right? And she tells her primary care provider she's always been a perfectionist. She's a straight A student, and she actually does a lot of extracurricular activities as well. So for instance, she excels in theater and she excels in dance. She's describing her symptoms to the PCP, and she's sharing that she experiences muscle tension, says it's difficult to relax, and she's been having a lot of worry about different topics, including her academic performance. And we know, again, she's always been a straight A student, her family's well-being, friendships, a romantic relationship, her future, and really the world at large, so world events. Lily has been irritable, but her irritability has increased over the past 2 months. So as a primary care provider learns more about what Lily's experiencing, they learn that Lily and her partner broke up 6 months ago. Sorry, her partner of 6 months broke up 2 months ago. So again, coinciding with that increased irritability. Now, following this event, her mood has decreased, and today in the office, she reports her mood as being just meh. Lily has a passion for acting, and she does have a supporting role in the upcoming school play, and she normally loves theater, but she hasn't been enjoying this activity as much as she used to. And she's also having difficulty remembering her lines for the play, and this is unlike her. At night, Lily's having trouble falling asleep. It's difficult to wind down, and there's a lot of rumination about that recent breakup, again, which was just 2 months ago. Lily is sharing that she does have a lot of thoughts around the breakup, for instance, feeling responsible for the breakup. She's been tired, and it's hard to focus on her schoolwork. And Lily says that she does want to do well in her classes. So again, she still, has that some motivation to do well. And we know she's been a straight A student in the past, but she shares that I can't seem to get my work done. She's been feeling bad about herself, feeling like she's not good at anything, some feelings of hopelessness coming up, as well as some feelings of worthlessness. She explains that sometimes she feels it would be easier if she weren't born because she doesn't want to worry her parents. She's never had a plan or an intent to end her life, and also no history of self harm or of suicide attempts. The primary care provider then decides to interview Lily's mother, who shares that Lily has been more irritable over the past 2 months. So, again, coinciding with Lily's report of her own irritability. And she's also noticed that her daughter's been sad and still appears to be very tearful about the breakup. She observes that Lily has been declining invitations to spend time with friends. And Lily did confide to her that sometimes she wishes that she weren't born. Lily's mother shares that Lily's always been hard on herself. She says that she and Lily's father don't place extra pressure on Lily to do well academically, but Lily does appear really driven to excel, both academically as well as in really any extracurricular activities that she's involved with. Her mother really expresses concern about Lily, about her current functioning and her overall well being. The mother volunteers that she also has experienced depression in the past, and this was responsive to Lexapro or escitalopram 10 milligrams daily. So now that we have the case, so again, we have a primary care provider who is learning about their patient, Lily, who's experiencing symptoms of depression, as well as we can see some symptoms of anxiety, and is interviewed not only Lily, but also has interviewed Lily's mother. Um, so this is really where with collaborative care, the care again, as Dr. Krishna explained to us so eloquently, this is really where the care begins, right? We'll learn a little bit more about Lily's condition by augmenting the interview with quantitative assessment, specifically those rating scales Dr. Krishna mentioned. So, within a collaborative care setting, these rating scales will sit within a registry. So, essentially, we can think of the registry as a system, if you will, to systematically collect rating scale information in order to monitor treatment progress over time. When we look at rating scales for registries or for any kind of measurement based care system, and of course, you can have a measurement based care system that doesn't sit within a formal registry. But when we look at these rating scales, we often will look at rating scales that are in the public domain because this will actually make it a lot easier to implement the rating scale within an electronic health record, especially for a large health system. And both Dr. Christian and I are parts of a larger health system. We also, when we're looking at rating scales for measurement-based care, we often will look for scales that are either a composite scale or a composite rating scale, where we can at least have one scale that will allow us to assess a wide variety of symptoms. And then we will often also administer scales that will allow us to assess scales within a specific symptom domain. So here's an example of one such public domain rating scale system, if you will, to guide measurement-based care practices. So in this particular system, we have the pediatric symptom checklist, which is that composite scale that will look at problems across multiple symptom clusters, such as anxiety, depression, inattention, for instance. Um, and then, as you can see in this particular system, we have a parent report on child as well as a child self-report for ages 11 and above. So this system is also even, I would say, a little bit more advanced in the sense that we're also able to systematically obtain parent report, which is nice to augment the quantitative information received by the child with quantitative information received by the parent. In order to assess family functioning, we have the Family Assessment Device. This is a McMaster Family Assessment Device General Functioning Scale, which is completed by the parent. To assess symptoms of anxiety, we have the Screen for Child Anxiety Related Disorders, or the SCARED, as well as the Generalized Anxiety Disorder 7, or the GAD-7, again, also available as a parent report, as well as a child self-report for ages 8 and above. To assess symptoms of ADHD, we have the SNAP-4, which is a parent report on child symptoms. Now, to look at our mood symptoms, so looking at those symptoms of depression, we have the Moods and Feelings Questionnaire, or the MFQ, which is a child self-report for ages 7 and above, and the PHQ-9, or the Patient Health Questionnaire 9, which is a child self-report for ages 12 and above. And then lastly, in order to assess substance use, we use the CRAFT, or the Car, Relax, Alone, Forget, Friends, Trouble. So each, as you can see in the CRAFT, there is a question in each of these particular areas that are listed out right before that acronym. And this will assess, again, give us a sense of any kind of risk factors around substance use. And that is a child self-report for ages 11 and above. So you can see in this particular system, again, there's one composite measure, a family functioning measure, and then 4 different specific symptom domain areas that are assessed. Again, also with a parent report on child, as well as a child self-report. And then you can see in the column on the left, the ages are specific for the validation of the scale. So for instance, we know that the MFQ is validated for ages 7 and above, and the CRAFT is validated for ages 11 and above. So only children of those ages or older would complete those measures. So now we're looking at the rating scale results for Lily. So again, to kind of big picture, see where we are with the story. Remember, Lily came in talking to her primary care provider. The interviews have been completed, and now Lily and her mother are going to be completing rating scales. So this is Lily's rating scale results. And we see for Lily here, the PHQ-9 score is 21. You can see in the bottom right of your screen. And that is what we consider in our red range. Now, Lily scores in the red on this particular rating scale because question number 9, which is thoughts that you would be better off dead or of hurting yourself in some way, is a 1. And any score in this particular measurement-based care system of rating scales will flag if there is anything above a 1 or above on question number 9. So Lily did flag for that. Now, Lily's SCARED score, her total score is in the orange, which is clinically significantly elevated. And if we look in the subdomains of the SCARED, and the SCARED, sort of as an aside, is really nice for this. Again, it's a public domain rating scale, but it's very helpful to look at these subdomains of anxiety. And we see that although her total SCARED score is 26, the areas that are elevated around generalized anxiety, as well as around school avoidance. And in this particular rating scale system, there's a little summary as to what each of the scores may mean. So this provides a little bit more information, but certainly even just having a numeric score is also very helpful. And her CRAFT is 0. I'll say that, yeah. So I pulled out some of Lily's results, and now let's look at Lily's mother. So if we look at the scores from Lily's mother, we see that the PSC, or the Pediatric Symptom Checklist, score is 21. We see a elevation in those, if you look on the left-hand side of the screen, and the internalizing problem subscale. And then on the right-hand side of your screen, we have the McMaster Family Assessment Device General Functioning Scale, which is in the green. So, noting to us that it appears that the family seems to have good communication and is supportive of one another, and things seem to be going well on the family level. We did not see any flagged or elevations in ADHD symptoms, again, on that right-hand side of the screen. And interestingly, Lily's mother didn't score as elevated or the scores were not elevated for the scared in terms of what Lily's mother's report is, but we do know that there is a slight elevation in spending a little bit more time alone. So perhaps we can see that there maybe is a little bit of isolation that may be occurring. And so I want to point out, as we're looking at these rating scales, what's important to do is to look at the overall, again, score on the rating scale, note whether there is an elevation in any of the subdomains, and then it can also be really helpful to look at any elevated individual items within a specific subdomain. That can also be really helpful in terms of knowing which symptoms to ask about and which symptoms we may want to monitor ongoing to make sure that we are really targeting our treatment to the optimal effectiveness for a patient. So we also put in here for you some of the response and remission criteria. Now, specifically, this is for the PHQ-9 as well as for the scared. But again, as Dr. Krishna mentioned, really, what is the key of measurement-based care, right? So in measurement-based care, we want to really make sure that the principle is that the rating scales are used to augment the interview and that they are meant to be actionable within that particular patient appointment, meaning that we are looking to enhance our assessment, enhance our evaluation, and again, really closely monitor treatment progress, as well as look for any residual symptoms, because we know that residual symptoms really, or any kind of subthreshold response, really is going to be a nidus for a potential recurring episode of a particular condition. So what are we looking at when we are looking for response? So for PHQ-9, in this particular case, we're looking for a 3 to 5 point reduction in score in a PHQ-9, and that is considered to be a clinically significant change. For the scared, we look for reductions of greater than or equal to 50% on the child report and greater than equal to 55% on a parent report, as being optimal for predicting treatment response, and a greater than 60% reduction on both reports as being optimal for predicting remission. And then a post-treatment score of 12 on the child report and 10 on the parent report in studies showed strong association with remission in the overall sample. So really looking at that as being something we may want to target as being under those numbers. And again, we are using all of these rating scales to really make sure that we're holding ourselves accountable as providers for our patients really meeting their treatment goals. And this will, again, help us to become more nuanced in the care we provide and really help us to work with our patients and families to monitor the symptoms over time. Okay, so in that last line, I think really speaks to around working with our families, speaks to the engagement piece. And I think this is really important in terms of the initiation of treatment. And I would say, obviously, of course, ongoing as well. Although in this slide, we're going to look at initiation, but it's really, when we're using the rating scales, of course, we're using them for our own purposes in evaluation and monitoring, but the rating scales themselves are really important and highly beneficial tools in terms of engaging our patients and providing psychoeducation about the symptoms they're experiencing and about their overall treatment course and the gains that they've made in care, whether that's actually felt by the patient and family or not. Because sometimes, patients may have made gains, but may not be quite aware of exactly the gains that they've made. But when they look at rating scale scores over time or individual symptoms over time, they may be more likely to recognize that. So there are many different ways that we can use these scales in terms of that engagement. So ideally, the primary care provider would thank Lillian and her mother for completing the rating scales. We always want to make sure that we thank people for engaging in these extra steps of their care. There's nothing worse than going to a provider's office and being asked to complete a bunch of forms that you are not sure were ever even viewed, right? Or taken into consideration in terms of the treatment plan. So we definitely want them to know that the primary care provider wants them to know that they did see those rating scales and thank them for completing the scales. During the appointment, the primary care provider also ideally will reinforce this concept of behavioral health vital signs and say, look, just as when you come to your annual physical, we take your height, weight, your blood pressure and your pulse, we also want to make sure that we are monitoring your behavioral health vital signs. So we want to know how your mood is. We want to be aware of the level of anxiety that you're experiencing or the level of worry or concern. So that's something that's important to discuss and also normalize by way of this vital signs analogy, if you will. Now, using Lily's rating scale results, again, the primary care provider would then review those results with Lily and her mother and review the symptoms of depression and anxiety, which we saw from several slides previous were elevated. And by engaging in a discussion in this way, we're promoting the patient's engagement in their care. We're asking them about the symptoms that are elevated. This also, in addition to providing psychoeducation, will teach the patient and teach the caregiver or the parent which symptoms need to be monitored. And the PHQ-9 itself, that is actually, if you look at each symptom on the PHQ-9, that is a criteria for depression, right? For major depressive disorder. So by going through a PHQ-9 with Lily and with her mother, that actually teaches them that when we talk about depression, these are the symptoms that we are looking at clinically. And of course, we want to understand symptoms that may be outside of these particular domains or in this particular, box, if you will, but we do want to be aware of what's happening within each of these 9 symptoms. This will also promote self-management because a lot of this, again, it creates a self-agency. And when you know what you're looking for, what you're really targeting your interventions toward for a patient, for a family, that can really help in terms of adherence or engagement with the treatment plan. Now, in some systems, there is a way to provide a patient handout to a family with, skill building boxes to really describe different things like behavioral activation, basic CBT skills, how to challenge negative and worried thoughts, how to recognize, negative thoughts or, inaccurate thoughts, depending on what specifically is being targeted. And if that is available, that's wonderful. But even if that's not available, a lot of this can happen in the appointment either with the PCP if time permits, or in the collaborative care model as promoted by the AIMS Center and our strictest definition of collaborative care with the two big C's collaborative care. Again, there is usually a care manager or a therapist that will work with the patient and family and can really take on this piece of it. Again, because we really want to devote all the time needed to this education and promotion of self-management. Okay, so now we're on engagement again using the rating scales. And in this particular case, again, Lily's primary care provider would discuss the symptoms with the family and discuss that any diagnoses made. And in this case, Lily was diagnosed with major depressive disorder as well as generalized anxiety disorder. And she was assessed to be at a low risk for suicide. Of course, remember, she flagged on PHQ-9 question 9 and we want to make sure that we are doing a suicide risk assessment, which in some cases may be augmented with the Columbia Suicide Severity Rating Scale, which is also available within the public domain. Now, treatment options at this point will be reviewed. Again, in this case, remember, this is a primary care provider reviewing the treatment options. The rating scales, again, will be used to help engage the family and promote and share decision making around the treatment options. So in this case, there's a discussion around medication as a potential option, as well as therapy as a potential option, or both. And in our case example, Lily and her mother will decide to hold off on any medication, but they do agree to work with the clinic's therapist to participate in cognitive behavioral therapy for depression and anxiety. Okay, so let's see what happens. So now we have a primary care provider who has used the rating scales to augment the evaluation. So our quantitative data are augmenting the qualitative piece, the clinical evaluation, and has initiated treatment. And in this case, the patient and family prefer to begin treatment with therapy, cognitive behavioral therapy. So Lily and her mother returned to the primary care provider 2 months later. And at this point, we learned that Lily has been meeting with her therapist weekly, but she is continuing to feel down and feel anxious. Now, the rating scales are obtained again, and the PHQ-9 revealed mild improvements in sleep, energy, and appetite, and no suicidal ideation. So she doesn't flag on this particular scale at this appointment, and her rating scale goes to orange. And in this particular system, there is a green, which is normal. There is a yellow, slightly elevated, an orange, clinically significantly elevated, and then a red, which was for safety. The scared revealed continued generalized anxiety symptoms, but no school avoidance this time. And Lily and her mother then discuss with the PCP how best to continue her care so she can meet her treatment goals. And they, at this point, are amenable to a trial of Lexapro or escitalopram to target her low mood and her anxiety. Again, noting that Lily's mother did really well on this medication previously. So the primary care provider will start Lexapro or escitalopram at 5 milligrams daily for 1 week, and then we'll increase it to 10 milligrams. So again, at this point, we have the primary care provider involved with the care, prescribing the medication, and then we have a therapist on board meeting with Lily to work on the depression and the anxiety. And I just want to point out the rating scales and this particular appointment with the PCP are obtained just prior to the appointment. And the rating scales are used within this clinical encounter to guide the care around symptom management in terms of the prescription of the Lexapro or escitalopram. So again, it's that measurement-based care definition, and really the one of the key fundamental features is that the information is obtained and utilized right away in the course of informing the treatment plan. Okay, so now 1 month later, or 3 months from that intake appointment, Lily reports improved mood during her weekly therapy appointment. Her PHQ-9 reveals improvements in mood, some residual symptoms, but we're seeing much more improvement. And if you look at the scores to the right, our PHQ-9 here is now 4. And we see our scared is also decreased at 19. So there is still continued generalized anxiety symptoms, no school avoidance, but we do see that in both of these measures, we have seen reductions in total scores. The Lexapro or escitalopram is continued at 10 milligrams weekly, and the therapy at this point is just continued. So we see that she's making some treatment gains. And especially if we look at the PHQ-9, the depression symptoms seem like they have responded in a more robust way to the anxiety symptoms. Okay, now at 4 months for intake, again, another month later, we see that Lily reports overall her mood is improved. Her PHQ-9 is now staying stable from that month prior at 4, but her anxiety seems like it's gone up again. So like she's flagging again a higher score. And we learned that she's really been thinking a lot about her college. She's been thinking a lot about the future and really discussing this a lot during the therapy sessions. Now, but she hasn't attended therapy for 3 weeks, and she's had a really demanding school schedule over the past 3 weeks. The PHQ-9 reveals an improvement in mood, as I mentioned, some residual symptoms, but I just want to point out for the scared, we saw that overall increase in score, but some more somatic symptoms that are coming up. So now the therapist at this point, I just want to point out because the last 2 visits, right, the PCP was not involved. These were meetings with the therapist, and the therapist, by way of this collaborative care model, is using the same system, the same measurement-based care system that Lily's primary care provider is using. And ideally, this system would be part of a larger registry that allows us to track scores over time and flag patients who are not improving. So we see that the therapist, again, has been tracking that PHQ-9, has been tracking that scared, and the therapist then alerts the primary care provider that Lily has been continuing to struggle specifically in the anxiety symptom domain, again, with that increase in the scared score. At this point, the child psychiatrist may be called upon to review Lily's case in the registry system and to talk with Lily's therapist. So this outreach likely happened by Lily's therapist. So in discussion with the case, the child psychiatrist recommends an increase in the Lexapro or escitalopram to 15 milligrams a day. As we know, higher doses of the SSRIs are more effective in targeting anxiety symptoms. So there's a recommendation to increase that medication dose to further target the anxiety and to continue with the therapy treatment. Okay, so that is an example of really of what the interactions would look like in a collaborative care model using the measurement-based care best practices really as a focus on the treatment plan, right, for Lily. So in summary, for this particular case, the rating scales. So rating scales, remember, they are a key component of a registry. The rating scales really are essential in terms of being able to work and treat patients within a measurement-based care framework. We're really being responsive to a patient self-report and using that self-report to inform our treatment plans so we can really make sure that our patients are making gains in their treatment. In this case, remember, we did assess symptoms frequently and concurrent to the clinical encounter. And remember, we use those results within the patient, within that encounter, within that appointment. They complemented the clinical interview. So again, as Dr. Krishna mentioned before, measurement-based care is not about obtaining a rating scale and then using that as a diagnosis or using that as a sole data point to determine how a patient is doing. But really, again, it's meant to complement the qualitative piece of what we do, which is that clinical interview. The rating scales, of course, inform the treatment plan. And when we use the rating scales as in terms of best practice, we can use the rating scales to provide psychoeducation about a diagnosis and really help a patient and family to increase their sense of agency around really monitoring the symptoms themselves and looking for symptom reduction. When we use rating scales, this will facilitate detection of improvement. And remember, when patients are hovering in that range of symptoms that are residual, but not to the degree to which they were before, right? So the residual symptoms, but that the patient and the family may say, look, I've seen a lot of improvement, and that may be true, but they still may be at risk of relapse. If we see that there are still some of those residual symptoms, we haven't brought them down to remission. So of course, we want to acknowledge and celebrate all of the gains our patients make, but we also want to make sure that we're not overlooking some of those residual symptoms that could create some challenges in the future. And then, of course, key is that treatment to target philosophy. In terms of the engagement, I just want to point out that there is also data, and Dr. Krishna reviewed this as well, around provider experience with measurement-based care. So there's a lot of data around the fact that when providers use measurement-based care, this helps patients to increase their confidence in their provider because they really see their provider as being more thorough. So in this case, a primary care provider and the therapist potentially would be seen as being more thorough. Remember, in this particular example, using this uh, collaborative care approach, the psychiatrist did not see the patient directly in this particular case. The psychiatrist consulted with the therapist and primary care provider. The engagement by using measurement-based care will also, again, as I mentioned, help patients better understand symptoms, understand diagnoses and what they're experiencing, and ultimately, I think help them to express themselves in a way that may better encapsulate what it is that they're experiencing and help to really communicate symptoms in a way that is helpful to their physicians and therapists. And with that, we hope that you have enjoyed our presentation looking at best practices and measurement-based care within a collaborative care setting context. It was a pleasure being with you here today, and we wish you all the best on your adventures in collaborative care and measurement-based care practices.